This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal World Neurosurgery, published in 2026, titled Prognostic Assessment of Surgical Strategies and Extent of Resection in Methotrexate-Based Treatment for Primary Central Nervous System Lymphoma, a Propensity-Matched Analysis.
This is a topic that hits home for many of us in the OR and the clinic. For decades, the dogma for primary central nervous system lymphoma, or PCNSL, has been biopsy only. The traditional teaching was that because these tumors are so chemosensitive, aggressive resection didn't offer a survival benefit and only increased surgical risk.
Exactly, Dr. Aris. But the prognostic significance of different surgical strategies has remained unclear in the modern era of treatment. This paper specifically looks at how surgical resection, RX, versus biopsy, BX, and the extent of resection, or EOR, impact clinical outcomes when patients are receiving high-dose methotrexate-based chemotherapy.
Let's dive into the study design. This was a retrospective analysis of 153 patients treated between 2014 and 2022. All these patients received MTX-based treatment. To handle the inherent biases in who gets surgery versus who gets a biopsy, the authors used propensity score matching, or PSM.
That PSM is crucial here. They looked at two primary endpoints, overall survival, OS, and progression-free survival, PSF. Before they even did the matching, the raw data showed a trend in favor of resection. For the whole cohort of 153 patients, the resection group had an OS that's 32 months compared to only 20 months for the biopsy group.
And the PSF showed a similar gap, 18 months for resection versus 11 for biopsy. But as we know, residents, the biopsy group often includes older patients or those with deeper, more eloquent lesions, which could skew the results. That's why the propensity-matched analysis is the heart of this paper.
Right. When they performed the PSM to create more comparable groups, the results became even more striking. In the matched analysis, the resection group showed significantly better overall survival at 36 months compared to just 19 months for the biopsy group. That p-value was 0.003.
And for progression-free survival in that matched group?
It was 22 months for resection versus 11 months for biopsy, with a p-value of 0.001. So we are seeing a doubling of the progression-free interval in patients who underwent resection.
Now, let's get into the deeper dive mentioned in the requirements, the extent of resection, or EOR. This is really the first time EOR has been evaluated so specifically in the context of PCNSL. The authors divided the resection group into gross total resection, GTR, and subtotal resection, STR.
This is where the paper gets very interesting for our surgical colleagues. The study found that GTR was significantly superior to STR. Patients who achieved a GTR had an overall survival of 39 months, whereas those with an STR had 26 months.
And if we look at progression-free survival for GTR versus STR, the numbers were 26 months versus 15 months. This suggests that the all-or-nothing principle might apply here. If you're going to resect, the goal should be GTR to maximize the benefit.
The authors also performed a multivariate analysis. They found that both the surgical strategy, meaning resection versus biopsy, and the extent of resection were independent prognostic factors for both OS and PSF. This really challenges the old biopsy-only paradigm.
I think a major concern for any neurosurgeon listening is safety. We've always been told that resecting these friable, deep-seated lymphomas is more dangerous than a simple needle biopsy. What did the paper find regarding complications?
Surprisingly, the study reported no significant difference in postoperative complications between the resection group and the biopsy group. This suggests that with modern neurosurgical techniques, aggressive resection can be performed safely in these patients.
So, to summarize for our residents and fellows, in patients receiving high-dose methotrexate-based therapy, surgical resection, and specifically gross total resection, is associated with significantly improved survival outcomes compared to biopsy.
Exactly. The paper concludes that while PCNSL remains a systemic challenge requiring chemotherapy, the initial surgical strategy plays a far more critical role in the prognostic assessment than we previously thought.
It's a compelling case for a paradigm shift. If the lesion is surgically accessible, we should perhaps be reaching for the aspirator rather than just the biopsy needle.
Definitely a study that will spark a lot of debate in our multidisciplinary tumor boards.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.